Good morning. Thank you to everyone. Thank you to SAGES and to the committee for allowing me to present today. I'm Poppy Addison. I'm a resident at Lenox Hill Hospital, and I'm a member of the Intraoperative Performance Analytics Lab at Northwell Health. Perfect. So I have nothing to disclose, but this work was supported by a 2020 SAGES robotic surgery grant. So thank you to SAGES for supporting this. While I wait for the 7 seconds, happy St. Patrick's Day. That has to be 7 seconds. So as a brief background, few studies currently test whether better skilled surgeons have better outcomes, despite this being fairly common sense. Given the constraints of data sharing and patient privacy, most studies available correlate a summary of the surgeon's skill with their overall clinical outcomes. Few studies actually correlate the specific patient videos with those specific outcomes. So to tackle this problem, we have a unique data sharing method that allows us to encrypt MRNs for third-party video-based assessment to allow us to study this patient-level data. We hypothesized that at a patient level, how well a case is performed correlates with postoperative outcomes. To test this hypothesis, we performed a retrospective review of prospectively gathered data. We studied patients undergoing robotic sleeve gastrectomy at a multi-institution healthcare system in New York, which were all bariatric centers of excellence. We included about 7 bariatric surgeons. Skill assessment was provided by the CSATS group, which is blinded, crowdsourced assessment with the GEARS score. And we adjusted for confounding variables, which were age, BMI, Charlson Comorbidity Index, and ASA. For those of you who are unfamiliar with the GEARS score, it's a Likert-based scale to grade robotic surgical skill across 5 domains, which are depth perception, bimanual dexterity, efficiency, force sensitivity, and robotic control. So a 1 indicates a novice or less experienced surgeon, and a 5 is an expert or a very skilled surgeon. It's been validated to stratify experienced surgeons versus inexperienced surgeons, and it's been crowdsourced review has been validated against expert review. So the column on the middle column here is just our descriptive summary statistics. So on average, our patients were young with a mean age of 41, had a mean BMI of 42, and were relatively healthy with the Charlson Comorbidity Index of about 0.7 and an ASA of 2.5. At 6 months, our excess weight loss mean was 72%, and at 1 year it was 75%. And you can note here our loss to follow-up. We started with 162 patients, and at 6 months we had 88, and at 1 year we had about 55, which is on average for these types of studies. So we, on the columns to the right of the screen, we performed a univariate screen to assess for confounders. So we found that age, BMI, Charlson Comorbidity Index, and ASA were all confounders for excess weight loss at 6 months and at 1 year. So to really assess our hypothesis here, we performed 2 analyses. On unadjusted analysis, excess weight loss at 6 months was not correlated with GEARS score, its total scores or any of its subcomponent scores. But after we adjusted for confounding variables, it was significantly associated. And this held true for excess weight loss at 12 months. So on a univariate screen, it was not statistically significant, but after we adjusted for those confounding variables, GEARS score and all of its subcomponents were significantly associated with excess weight loss. We also evaluated serious morbidities. We defined these before the study as wound dehiscence, medical complications including stroke, cardiac arrest, MI, things of that nature, and an anastomotic or staple line leak and a postoperative hernia. We evaluated 30-day complications. We had very few patients overall who experienced serious morbidity. We had about 9 patients, or 5%. So there was insufficient evidence to conclude there is a correlation between serious morbidity and demographics or GEARS score. But again, considering how few complications we had, there may be some kind of association here. We just need to correlate this data in a larger review. So in conclusion, for patients undergoing sleeve gastrectomy, surgical skill as assessed by the GEARS score was correlated with excess weight loss, suggesting that better performance of the sleeve may result in improved postoperative weight loss. Thank you for your time, and I'm happy to take any questions.
Thank you very much, Dr. Addison. Any questions from the audience? We'll have 2 minutes following each talk. Well, maybe I'll kick it off. So, I think this is a very interesting study. There's a lot of interest in video-based assessment of surgical skill and the correlation with sort of technical outcomes. But this is the first study that I've seen where it actually looks at correlating video-based assessment with actual weight loss outcomes. And one of the things that we sort of accept as a tautology when it comes to bariatric surgery is that the patient's behaviors after the operation are equally important to what takes place in the operating room. So how would you connect the fact that a technically performed operation, video-based assessment-wise, while it looks good, why would that lead to better weight loss? What is the hypothesis there?
Right, that's a great question. That's really the next step for our lab at Northwell. So right now we're looking at kinematic data to figure out exactly what is happening in the operating room that may account for these patients doing better. So is it about the crural dissection? Is it about the angle of the staple line? So our step next is to, without mentioning any specifics, we're using a robotic data recorder that will record spatially and temporally exactly where the instruments are in the surgical field to figure out, are there differences there that may account for it? So we could pinpoint, surgeons who have patients who lose more weight afterwards are spending more time up in the crura, or are they spending more time later on? I think there's a discussion about oversewing the staple line. Could that tissue handling impact it? So the next step really is to figure out in granular detail what exactly is happening in the operating room that could account for it.
Good morning. Excellent presentation. I think this is an important new avenue to pursue, looking at the actual quality of the operations. My question is this, I'm sorry, Christine from Edmonton. The gear score seems to be driven around sort of the expertise with the robot rather than expertise with doing the sleeve.
Right.
And so, the overall complication rate for sleeves is relatively low, so with an N of 162, I'm not surprised that you didn't find a lot of correlation. But a lot of the technical things of doing a sleeve might correlate with more subtle complications, things like nausea and vomiting, dehydration, readmission, things like that. Did you look at any secondary outcomes for those procedures to see if perhaps, your angularis being too tight or wavering of the staple line, things like that can lead to the sort of the less serious complications?
Yeah, absolutely. That's a very good point. So to first answer, we use the gear score as opposed to anything procedurally specific because our lab is, we do a lot in bariatrics, and the PI of the lab, Dr. Filocori, is a bariatric and foregut surgeon. So we started with this, but really the idea of this is to expand beyond specifically a sleeve and to say for robotic surgery in general. So we didn't want to create any more of these Likert-based scaling grading systems. We wanted to use a universal one. So is the gear score meaningfully in any way predict outcomes, not just for sleeve, but for next step is inguinal hernias for us, and then ventral hernias. So we wanted to use something very general. But that point about there are very unique things to a sleeve that we're not accounting for, but we're hoping that using the kinematic data, we'll be able to answer those specific sleeve questions. And you're absolutely right. When we use the kinematic data, we're going to be looking at those more subtle procedural specific complications like PO intolerant to readmission for dehydration or something like that. So that's absolutely our next step.
Yeah, it seems like those things should be sort of tied together.
Right.
Separate analyses, like how good are you on the robot and how good are you doing the sleeve?
Yeah, exactly.
Thank you very much.
Thank you.
This is a very fascinating topic. We should utilize it more as high-performance athletes. Use the things surgeons can benefit from that.
Thank you.
Our next speaker is a medical student, Bridget Anderson, and the topic of her presentation is increased incidence of marginal ulceration following sleeve to Roux-en-Y gastric bypass, a multi-institutional experience.
Hi, my name is Brigitte Anderson. Like was said, I'm a third-year medical student from Thomas Jefferson University, and I'd like to thank SAGES for the opportunity to present our work today. I have no financial disclosures. Marginal ulcer formation is a known and serious complication following Roux-en-Y gastric bypass. There's a wide variability in the reported incidence of marginal ulceration after primary bypass, ranging anywhere between 0.6% and 25%. Previous studies have supported the role of local acidity. Patient-related factors have also been implicated, such as diabetes, smoking, H. pylori infection, and steroid or NSAID use. Operative risk factors, such as anastomotic technique or pouch size, may also contribute. While surgical intervention for marginal ulcers is rare, it may become necessary in refractory cases or those that result in complications such as perforation, persistent bleeding, anastomotic stricture, and gastric fistula. Studies have reported a marginal ulceration recurrence rate between 15 and 33%, revealing the true burden of this complication. This translates to increased healthcare utilization and decreased quality of life for the postoperative bariatric patient. Over the past decade, there has been a significant increase in secondary bariatric procedures, such as conversion of gastric banding or sleeve gastrectomy to Roux-en-Y gastric bypass. These are typically performed due to ineffective weight loss or refractory GERD. The clinical impact of marginal ulceration in this population has yet to be defined. Anecdotally, our group suspected a higher incidence of marginal ulceration following conversion of sleeve gastrectomy to gastric bypass. The aim of this study is to evaluate the incidence of and risk factors for the development of marginal ulceration after primary versus secondary Roux-en-Y gastric bypass. 3 participating institutions retrospectively queried their institutional electronic medical records and MBSA KIP database to identify all adult patients who underwent primary bypass, band to bypass, and sleeve to bypass between 2014 and 2019, ensuring at least 1 year of follow-up. Patient demographics, operative data, and postoperative outcomes were compared between cohorts to identify the incidence of marginal ulceration and the contribution of known risk factors. A total of 860 patients were identified and included in this study. 68% underwent primary bypass, 21% underwent band to bypass, and almost 11% underwent sleeve to bypass. Mean patient age was 45.9 years, and the majority of patients were female. Average preoperative BMI differed significantly between groups, with the sleeve to bypass cohort having a significantly lower BMI. Significant differences were also seen in the indication for revision, with the main indication for sleeve to bypass being GERD and that for band to bypass being insufficient weight loss. The majority of procedures were performed laparoscopically. Patients undergoing sleeve to bypass were significantly more likely to undergo concomitant hiatal hernia repair compared to the primary bypass or band to bypass groups. There was some variability in anastomotic technique, although the majority of gastrojejunostomies were created using a linear stapler and a hand-sewn common enterotomy. A total of 50 patients developed marginal ulceration during this study period for an overall incidence of 5.7%. The incidence was significantly higher for patients who underwent sleeve to bypass. The rate in these patients was almost double at 11.8%, and the mean time to marginal ulceration was also significantly shorter at 9 months compared to 27.3 months for primary bypass and 33.5 months for band to bypass. In those who developed marginal ulceration, there was no significant difference in risk factors between the groups, specifically H. pylori status, NSAID, steroid or tobacco use, or anastomotic technique. GERD was a more common indication for sleeve to bypass compared to band to bypass. No significant differences existed between medical versus surgical management amongst the 3 cohorts, nor were differences seen in the rates of marginal ulcer resolution. To our knowledge, this is the first study to investigate marginal ulceration, specifically following secondary Roux-en-Y gastric bypass. We identified that patients undergoing sleeve to bypass had a twofold higher incidence of marginal ulceration and a shorter time to ulceration than those undergoing primary bypass in the absence of differences in previously identified risk factors. This suggests that the increased risk of ulceration may be related to inherent physiologic or anatomic differences between the two procedures. Such differences could include larger gastric pouch size. It has been shown that for each 5 centimeter cubed increase in gastric pouch size, there is a 2.4-fold increase in the odds of marginal ulcer formation. Patients undergoing sleeve to bypass may be more likely to have a larger pouch or retained fundus, predisposing them to ulceration. Poor perfusion and long-term healing may also explain in part the higher marginal ulcer incidence in this setting. During sleeve to bypass, one is required to restaple the proximal stomach. As previous staple lines may be well embedded in tissue and scar, it is possible that crossing staple lines during pouch formation may lead to tissue with suboptimal perfusion. And finally, conversion of sleeve gastrectomy to bypass creates an antrum that is in discontinuity with the proximal stomach. This allows for unopposed exposure of the antrum to the alkaline environment of the duodenum, which can cause uninhibited gastrin release and promotion of an ulcerogenic state. Additional studies are needed to test these theories. There are limitations to this study which are worth noting. While the MBSA KIP database is prospectively maintained, it is limited to predefined data points. Any additional data were collected retrospectively. Additionally, our study is unable to assess for gastric pouch size. Finally, the study design accounts only for patients who maintained follow-up within the institution where they had surgery. These data do not account for any complications that were managed in another healthcare system. As such, the true incidence of marginal ulceration may be higher than reported. In this multi-institutional cohort, patients undergoing sleeve to bypass have a significantly higher incidence of marginal ulceration and shorter time to ulceration than those undergoing primary bypass, possibly related to inherent anatomic or physiologic differences. As the number of patients undergoing sleeve to bypass increases, further studies are needed to better understand the natural history and pathophysiology of marginal ulceration in this unique patient population. In the meantime, gastric pouch size should be carefully assessed, and resizing should be considered when performing sleeve to bypass, particularly in patients with GERD, as the primary indication for a revision. Additionally, the presence of retained antrum syndrome should be considered in patients with refractory marginal ulceration after sleeve to bypass. Thank you, and I'd be happy to take any questions.